So this evening, Jenny's invited me to talk about hemiplegia. Now, hemiplegia is a vast topic, and I didn't really know where to start or what to include. I don't want to sort of bombard you with facts and figures. I want to make it practical and relevant. And I'm also very aware that I'm speaking to an audience of parents who I'm guessing have children with a diagnosis of hemiplegia. So you're probably going to be far more knowledgeable than I am in many areas. So I'm going to keep it very physio focused. We're going to talk about physical difficulties associated with hemiplegia and the role of the physio and how we can help. So the areas I am going to cover, to start with, I'm going to talk about the different presentations of hemiplegia. So some hemiplegias can be spastic hemiplegias, some can be paralysis and weakness, some can be dystonic. So I'll go into a little bit more detail about the types of hemiplegia that we see. I'm going to talk about the early signs of a hemiplegia and how we approach treatments for the infant. I'm going to look at common presentations and difficulties, which hopefully will be generalised and useful to everybody. And then we can look at specific treatment ideas, looking at functional exercises, stretching, positioning, discuss strengthening, which I hope will be quite practically based for you. I will then talk about adjuncts to physiotherapy, because as physios, we do use some methods which aren't hands-on, which are quite useful to know about. You might know about them all, or I might introduce you a few different ones. So I'll just cover adjuncts to physio. If we've got time, I might run through a little sort of upper limb treatment session that I would do, and you can pick some ideas out of that. Also, if you've got time, I can talk about some toys and things that might be useful to encourage use of upper limb, and then some useful websites. And like Jenny said, if we take questions at the end, if you've got specific issues, then that would be fantastic. That's what I'm going to cover today. So hemiplegia is damage specifically to one side of the brain. So the difficulties the child experiences are mostly pronounced on one side. Having said this, we often see difficulties on the unaffected side, but that is a result of the abnormal movements on the affected side. It's predominantly a one-sided problem. So hemiplegia does fall under the umbrella of cerebral palsy if the child had damage to the brain either before, during, or up to sort of 1 to 2, even 3 years after birth. So it's basically damage to a developing brain, not a developed brain. So it might fall under that category of cerebral palsy. All your children, if you are tuning in this evening, have a diagnosis of infantile spasms as well. So it may be that a seizure has led to the damage in the brain, which has caused the hemiplegia. It may also be that your child was born with an abnormality within the brain that has caused a hemiplegia and the abnormal brain activity. So it could have come from either direction. Also to note, hemiplegias can also be transient. So as a result of a seizure, you can have a hemiplegia, which can last minutes, hours, days, even weeks, but can actually fully resolve itself. So that's quite interesting to note. So hemiplegia itself covers a huge spectrum of movement disorders, and also sensory impairment issues and other associated problems. So if we think a little bit about the abnormal control of muscle activity, which I'm going to be focusing on, we're talking about either weakness or tightness, so spasticity and overexcitement of muscles, and the dystonic, which I'll talk about in a little bit more detail, is more of an uncoordinated movement disorder. And all of these can lead to functional difficulties, so things like walking, dressing, writing, which you're all quite aware of. So the sensory impairment side of things is a major part of hemiplegia. and it's all about the information coming from the outside world to the affected side of the body and how the body processes that information and allows that side of the body to work. So it could be due to a lack of sensation. You often see neglect sometimes if the sensory receptors are not as responsive on that side, so you tend to neglect that side of the body. And also proprioceptive difficulties if the child is not actually so aware of where that limb is in space. It finds it difficult to use it functionally for weight bearing, etc. Then again, that will decrease the use of that side of the body. And talking about associated difficulties, there are lots of other associated problems with hemiplegia, things like visual problems, speech, perceptual difficulties, cognition, also emotional management can be a big issue, and behavioural difficulties. So lots of things to consider when we're talking about hemiplegia, and we can touch on most of those, but my focus this evening as a physio is going to be on gross motor difficulties caused by damage to the motor cortex in the brain, which controls muscle activity and movement. Right, so I said I was going to talk about the different presentations of hemiplegia. Depending on how your children's muscles have been affected by the hemiplegia, obviously dictates the treatment approach that we use. Now, the most common presentation, which most of you are probably aware of, is the spastic hemiplegia. So this is where the muscles are overexcited, oversensitive, quite tight and stiff. And this makes the fluid control of the limb very difficult. So just quickly explaining spasticity. So if we're thinking about elbow function and reach, if you've got a spastic muscle in your biceps, so it's spastic and it's overworking and pulling that elbow up, then it's going to inhibit the use of your opposite muscles here, which are your tricep muscles, which extend the elbow. So you've got this overactive muscle pull, the spasticity, meaning that we can't use the opposite muscle for that extension. So that's what spasticity is. It's an overactivity of a muscle. And that's a common presentation. Obviously, lower limb as well, we'll talk about separately, but that was just a demonstration of how spasticity can affect movement. So a lot of children with hemiplegia we see have a spastic hemiplegia. Now, some children present with weakness rather than spasticity and even paralysis. So if we think about maybe a drop foot, if you had a spastic hemiplegia, then the muscles at the back of your calf will be really, this is the leg for a minute, the muscles at the back of your calf will be overworking, pushing that toe and ankle down towards the floor. However, if we're talking about weakness or paralysis, we don't have that pull, we actually have a drop, because the muscles that pull the ankle up, the dorsiflexor muscles, are too weak or they're not working in order to pull the foot up. So you can see that that's very different from a spastic foot to a paralysis, a weakness. So obviously our treatment approach would be very different. And you can have spasticity and weakness together. And that's really the sort of physiotherapist's role, to assess your child and see where the problems lie, what the muscles are doing, and how we approach treatment. There's a third presentation of hemiplegia, which is not very common. I have seen a couple, but it's not particularly common, is the dystonic hemiplegia. Now, dystonic means a fluctuation in muscle tone. So it's when the limbs go from high tone to low tone. It's a fluctuation of that muscle tone. This is due to damage to an area, a very specific area of the brain called the basal ganglia. And that's what is damaged or affected in people with Parkinson's disease. So you often see that sort of Parkinsonian tremor. And that's what you can see is caused by the dystonic element of the brain damage. So you can also see, it's all very involuntary movements. You can see sort of regular pattern writhing movements in the limb. Again, that's because the muscles are going from high tone to low tone, high tone to low tone. It gives this sort of writhing pattern, which is sometimes called apoptosis. If you've got really high fluctuations in muscle tones, at very high to very low, you can get very, very strong severe spasms. So I've seen a little boy whose arm just sort of gets locked in this position because it's a very high tone, but when it relaxes, it can come back down. So those are some of the things you see with the dystonic hemiplegia, but they are much less common. But you can see from this that there isn't really a recipe for physio for hemiplegia. There's no one size fits all. It does take careful assessment to work out what is required for physio and treatment. Having said that, there is some general advice, which I'm hoping to be able to give you tonight, which would be quite useful. And if you do have any specific problems or issues, questions, then we'll address those at the end. So generally, with hemiplegia, the physio aims are to work for symmetry. You've obviously got one side of the body working very differently from the other. And we want to work for symmetry of movement and also symmetry of posture. It just makes sense that if one side of the body is working differently, then you are going to get postural changes. There's going to be a muscle imbalance. So you need to be working for symmetry of posture as well as symmetry of movements. That's one of our real focuses of treatment. We're also working to normalise muscle tone. So if we've got really tight, high tone muscles, we want to try and reduce that spasticity. If we've got weak muscles, then we want to strengthen those areas. So we want to normalise that muscle tone. If we've got dystonia, whereas fluctuations in tone, what we're aiming to do is reduce those fluctuations so they're not so big. You'll still have the fluctuations, but you can reduce the level of fluctuations in tone. So it's about normalising muscle tone. In all presentations, we're working on maintaining joint range of movement and preventing contracture. So in spasticity, if you've got a bicep working really hard, pulling that elbow into flexion, is not very often being extended, obviously the tissues, the soft tissues in that area are going to get tight. And that elbow is at risk of getting stuck into a little bit of flexion. So monitoring joint range is really, really important. Also with weakness, if you've got a foot drop and the foot isn't really ever coming up to that 90-degree angle, then again, you're still at risk of contraction. Even though it's a weakness, you're still at risk of contracture. So physio is really looking at joint ranges of movement in the affected side to make sure nothing is getting tight and stuck. And ultimately, we're trying to work to maximise independent function. That's what it's all about. So those are our general aims of physio in all cases of hemiplegia. So if we start off looking at the early signs of hemiplegia and our treatment approach in infants. So we're probably thinking of the younger child now. So thinking about infants when they're playing, you might notice when they're lying under that baby gym that there's a very dominant side. One side is working a lot more than the other. That's the first thing you'll pick up. And it may be that the affected side, you'll see the hand is often fisted and doesn't open out. So you've got one hand sort of batting at toys. This one isn't working so hard, isn't coming up against gravity like the non-affected side, and you have a little fisted hand. Also, when coming hands to mouth, you'll notice the difference that one hand might not come to mouth, but even if it does, it remains quite clenched and quite stiff. So that's one of the very common signs we pick up with hemiplegia to start with. Also, when the infant is lying on their back and kicking their legs, you have that sort of cyclical movement of legs. You might find that one hip has lovely full range of movement and looks quite free and loose, and the other side just looks a bit stiffer. Maybe the knee isn't coming quite as far up to the chest. Still getting movement, but not that freedom of movement, and the leg generally feels a little bit stiffer. So that's what you'll see in supine play, is that that just difference in the two sides of the body. You do also pick up signs when they're on their tummy, prone. When they're in tummy time, there's often a preference of head turn as well, because of that neglect we talked about earlier, the lack of information coming in from the affected side of the body. Then the head often turns away, and the dominant hand will be used for reaching in prone. So you will see asymmetry in prone as well. And also rolling, you might see that your child just rolls to one side and not the other. Again, it's because they're leading with that dominant side. So that's something to pick up on. Also in standing, if you hold the infant up in standing, so their feet are on the floor, you might see that one side the toes are quite clawed. So when the foot touches the floor, they're screwing up their toes rather than having that nice flat foot. You might see that they're up on their tiptoes a little bit. And you might see that they're just not taking weight on that side so much. All the weight is very much on the non-affected side. It can be that the weight is very much on the affected side and they're using this one to step, and the affected side is a prop. But you often see this sort of toe clawing, which comes with it. Motor milestones might be a little bit delayed. It's not always the case. Obviously, it depends on the amount of damage that has occurred to the brain and how affected the muscles are. But many children with hemiplegia will hit all their motor milestones, get up to walking, and it's not until they're up on their feet walking that you start to notice a little bit of asymmetry. But generally, children with hemiplegia do get up onto their feet and do walk and run. Obviously, that's if it's a pure motor cortex, a pure physical difficulty we're talking about. There's lots of other influences we've mentioned which could impact that. If it's a pure motor cortex injury, most of those children will get up and walk, which is great. Crawling is an interesting one. We often pick up hemiplegics at the time that the children start crawling. Obviously, with crawling, you need to have weight bearing through two limbs. And just a note, which I haven't mentioned with a hemiplegia, sometimes the upper limb is absolutely fine and it's just the leg that's affected, and vice versa. But normally in crawling, when you take the weight through two arms, you might see that actually, because one side the child doesn't like weight bearing through, they do this sort of 3-point scooting. So they're not in a 4-point position. They'll use one leg and one arm to scoot along. And that's often the point at which we pick up the hemiplegia, when they're not taking weight through that arm. And there's that 3-point crawling. If your child isn't using that 4-point weight bearing position that I go on about all the time, we will definitely put that into their physio program. Both occupational therapists and physiotherapists alike love that 4-point crawl position. It's so important for development in so many different ways. So at this stage in development, as physios, we don't often push the walking. We know that's going to come. And we're very happy if a child is in 4-point and crawling, because every time they're crawling, weight bearing through their upper limb, they're getting beautiful proprioceptive feedback, lots of information coming through that limb, lots of lovely stretching is happening. And it's great for fine motor development as well to have that flat hand weight bearing. So we really love crawling. And if your child isn't crawling, then we will definitely put that into their program. So make sure your child is playing in that, or is positioned in that 4-point position. So in the early stages, the infant stages, our aims primarily are to work for symmetry and for that midline orientation. It's really important that babies learn where midline is. Obviously, in a hemiplegia, that's going to be very distorted for them because they're very much working one-sided, and we need to help them find midline and work towards midline. So one of the beautiful positions to develop that is side lying. Obviously, if your child is side lying, I've got my baby, yeah, bring him in. So if he's side lying, gravity brings absolutely everything to midline. So this hands will be in midline, legs will be relaxed, head is in midline, and it's just a lovely position to play. So lots of side lying, lots of noisy sensory toys in that midline position is a beautiful position to develop that midline orientation and that symmetry. So we like that. Also, when playing on their backs, I've talked before about the importance of nesting. So again, I've got my good old favourite, the V pillow. So by using the V pillow and popping your baby in the V pillow, you can use the cushion to bring both arms forward. So often when gravity is working down and babies are flat on their back, the affected limb will just be out to the side and this arm will be coming up. So in a nested position with your V cushion, you can bring both shoulders in, make sure the baby's really nicely supported and can get those hands to midline, hands to mouth. And that's that supine midline play position. It's also a nice position to work hands to feet to play. Again, that's the midline orientation. This little piggy, lots of toe play. Also crossing midline, getting opposite hand to opposite foot is a lovely game to play, using both hands and stimulating, sensory stimulation of both feet and both hands, using different textures and lots of different sensory toys in that position is really useful. It's also really nice at this stage to get a feel of your child and how their limbs move. So I do encourage at this stage, if you have got a baby with a hemiplegia, just to do the leg cycling exercise with them and just have a feel. You'll feel that one leg feels nice and loose and can come up, and you might feel this one is a little bit stiffer. So just have a play with a little bit of rocking, a little bit of jiggling, see what relaxes the leg and see if you can take that leg through full range. So it's really nice just to do a little bit of cycling with the legs and just see if that relaxes the legs off as well. So what we're trying to do is normalize tone, so just the cycling of the legs. Also bringing legs apart, so that's what we call abduction. So just doing little games, bringing legs apart. Again, just doing a bit of jiggling, a bit of rocking, can help relax, but it's really nice for you to be able to feel the differences in the legs and work out what relaxes their muscles. So gentle stretches at this point is still really beneficial. So just taking your baby's hand right above their head and right back down, and also crossing the body to the opposite shoulder and opening the arm out. All lovely stretches to do at this stage. Just up and down, out and across the body. Okay, so those are just a few ideas for the infant stage. So as the child gets a little bit older and gets up on their feet, there are some very common patterns of movement that we see with children with a hemiplegia. So I will just run through some of those with you so you can be aware of what to be looking out for. If you pick up any of these problems, then you can act on them straight away and stop them becoming a significant problem and leading to contractures and tightness. So I'll just put the baby away. So thinking first of upper limb, as I mentioned before, is the fisted hand. You very often see a child with a fisted hand and they find it quite difficult to open the hand out. Also that thumb, the adducted thumb, you often find the thumb is across the palm, so they grip, holds the thumb in, and that thumb adduction is a very classic hemiplegic trait. And I will go through stretches in a minute to show you how you can help these and give you exercises, but that's something you often see, so look out for that. Also, wrists tend to be quite flexed. That wrist extension is a really functional position, and that's what we need for many activities. but children with a hemiplegia often tend to flex their wrist down rather than extend it. So you've got the thumb adduction, the fingers flexed, and the wrist flexed, which leads to quite a tight little hand. So have a look at that, see what range of movement your child's got in their wrist as well as their fingers, because the tendons that flex your fingers run all the way down to the elbow. So you need to incorporate the wrist extension and the finger flexion to get a full stretch. You might find that you can do wrist extension, but you can't get the fingers open. So have a feel and see if you can get that full range of movement. That's to look out for there. Elbow flexion is a common problem, as I mentioned, with the bicep. So you might find that your child doesn't often completely extend their elbow. So you've got the fisted hand and the flexed elbow. And very, very commonly is the wrist, the forearm pronation. So the forearm turning that way, not that way. So if you imagine carrying a tray, that is the position that we want. It's that open palm up, palm to the ceiling position. And a lot of the children with hemiplegia tend to do the reverse, which again is really not a very useful functional position. That is the functional position we want. So just have a little feel of what it feels like to bring your child's palm up to the ceiling. So it's that supinated forearm that we're looking for. Shoulders tend to be a bit internally rotated. So a shoulder, you have external rotation and internal rotation. The rotations you get a shoulder. In a hemiplegic shoulder, you often get internal rotation. So it's that opposite, the external rotation, that can get a bit tight. So look out to see if you think your child is bringing their shoulder in. You can have externally rotated shoulders in hemiplegics as well, but this is just sort of common problems that we see. Also, we need to think about the shoulder girdle. So your shoulder blade, the big triangular bone that sits on your back, can often get really glued down. So when you're raising your arm up, it's not just your shoulder joints, your bones in your arm that are moving. Actually, that big flat triangular bone on your back has to glide across your back as you lift your shoulder. And some of the muscles around there can get really tight and sticky. So when your child's trying to reach their arm up, they can't get much further. And that's not necessarily because of what's going on in the arm, it's what's going on around the back. So it's really important that as physios, we can keep an eye on that shoulder blade to make sure that it glides across the back. It glides across and rotates up when you move your shoulder. So just to be aware that it's all around the shoulder, it's not just the arm that we're looking at. And also up in the neck can get really tight. So the trapezius, this muscle here, can get quite tight as well. So just trying to get your child to drop shoulder down and stretch out the side of the neck, that can get quite tight. So going on to lower limb, if we start off at the hip, a child with a hemiplegia often has what we call a retracted hip. So the hip is actually sort of pulled back a little bit. And when it's pulled back, it's also sometimes rotated in. That's what we see. So you see that interning of the limb. So this is a leg. It's being pulled back a little bit and rotated in. So it's that internal rotation and being pulled back. That's what you often see at the hip. Knees, they can be flexed or they can lock back into hyperextension. It depends a bit what's happening on the foot as to the sort of the biomechanics of what happens further up the leg. But you might find that a child walks with a bent knee, or you might find when they're standing on their affected leg that they flick their knee into hyperextension. It can do one of two things. So have a little look at that. If there's a problem there, you can address that. The ankle is often plantar flexed, so pointed down. So when the child stands, they're up on their tippy toes. When they walk, they don't get that lovely heel strike and movement over a flat foot. It tends to be up on tippy toes, which is a very common problem. And we can talk about that in a bit more detail in a bit. And then the foot itself, The foot can, what we call pronate, so roll over and collapse, or sometimes children do the complete opposite and they pull their foot out here, so they have a really high instep, so the foot actually curves in rather than rolls over. So it can do one of two things. Obviously, treatment is very different depending on what the foot is doing, but those are the two presentations you can see in the foot. A really important thing in hemiplegia is to keep an eye on the spine, because you've got different activities going on either side of the body. You can get quite a bit of asymmetry in the spine. So you might see that your child's ribs stick out a little bit more on one side than the other, and that's because of a rotation in the spine. So the spine itself is straight, but there's a bit of rotation happening because of that muscle imbalance in the trunk. So that's something to be aware of. We look out for any increased rib humps. And also the scoliosis, so the curve in the spine. That can happen for a number of different reasons. Either you've got too much pull and flexion on one side, so it's pulling one side down. It may be because of a leg length discrepancy. Could be for a number of reasons, but we want to make sure that the spine stays nice and straight. It's really important. So physios keep a close eye on spines. Also, you can get what we call kyphosis, which is a sort of bending forward at the back, a bit of a hump in the back, because that shoulder girdle can often be pulled forward and quite tight, and you see that sort of posture. So we sometimes have to work on extension of the spine, so we keep an eye on that. So as you move down the spine, you come to the pelvis, and the pelvis itself as well can be really affected by a hemiplegia. So the pelvis is a big block of bone, basically, at the bottom of the spine, and that too can be rotated. Like the spine can rotate with a muscle imbalance. I was talking about before about the hips being retracted and pulled back. So if that happens, the pelvis will be pulled back, and you'll see rotation at the pelvis. So physios keep an eye on that, because that can have an impact on hip position. And we're very hot on hip positions and keeping hips aligned. And also you can have a lateral shift in the pelvis, so it's pulled up higher on one side than the other. So not necessarily rotated, but it can be pulled up higher on one side, as can the spine. They're usually linked, the pelvis and the spine positions. If one moves, then the other moves. I did touch on leg length discrepancy. That's something we often see with hemiplegia, because of reduced weight bearing on the affected limb, because of proprioceptive problems or weakness or abnormal movement patterns, and the child isn't taking as much weight on that side, then there isn't as much. Weight bearing stimulates bone growth, so that can affect the length of bone. Also the muscle activity, if there's reduced muscle activity around the bone, it's not stretching and tensioning the bone, so it doesn't grow as much. And blood circulation, you can have poorer circulation in the affected side, and that can affect bone growth. There's lots of reasons why you might get a discrepancy in leg length, and that can really affect posture and alignment as well. Interesting to note, we talk about real leg length discrepancies and apparent leg length discrepancies. Now, a real leg length discrepancy really needs to be measured on an X-ray, so you can literally measure the bones and see if there's any disparity. An apparent leg length discrepancy is something that it looks like you've got one leg shorter than the other, but actually it's due to muscle pull and muscle imbalance. So actually, when you straighten the child out, stretch them, their legs are equal. So that's when we talk about real and apparent leg length discrepancies. Note those. So going on from though, that is the sort of the common things we see in a hemiplegia. So from that, we can take that we need to stretch. We need to maintain ranges of movement. So I'm just going to run through some simple stretches that you can do. So passive stretches are really useful, but also active stretches, so getting the child to join in and take their joints through full range of movement is really beneficial. So they become more aware as well as being strengthening and proprioceptively fantastic. It's really good for them to be aware of their limbs themselves. So the hand, obviously, but start with that thumb. If that thumb is tucked in, that just makes the fingers grip and everything goes. So getting that thumb joint at the base and bringing it out can just be a beautiful stretch to just open the hand up. So it's literally just bringing the thumb out, and you can relax the hand and have a lovely stretch of that thumb and fingers. So once you've got the thumb out, you can then more easily stretch the fingers and stretch the wrist out. That's a really nice stretch to do, getting the thumb and fingers open. An active way of doing that for children, I do chicken wings. So it's hands together and then getting them, they can probably do that, and then trying to get them to bring their elbows out like a chicken. So chicken wings is a nice stretch for that hand and those fingers, and thumb as well. So chicken wing stretch is a good one. And any sort of weight bearing, if you can see, if a child is in 4-point kneeling in that position, you can see that my thumb is out, well, probably can see, and my fingers are stretched, my wrist is extended, and that's a really fantastic stretch. So any sort of weight bearing through the hand will be a lovely stretch as well for that thumb, fingers and wrist. Really important. And you might find if there's a lot of tightness, you can't do all three together, like I mentioned earlier. It might be that you have to do a bit of a rich wrist stretch with fingers flexed, and then let the wrist go and then stretch the fingers, rather than trying to do it all together. But it's absolutely fine just to do each one in isolation if you can't get a full stretch of everything. But getting that thumb out, opening fingers and getting the wrist up is a really lovely stretch. Onto the elbow. Obviously, bringing that elbow out into extension is really valuable. And if you can do that in combination with a palm up stretch, so you're getting elbow straight. Once the elbow straight, then bring that palm up. Ideally, if you can get flat hands open and thumb open, that is a beautiful stretch for the whole of the arm. But like I said, if you can't do it all, then it's absolutely fine. Just to get the elbow and you're keeping a clenched hand is okay. You're just working on that palm up supination. So extending the elbow, rotating to the ceiling. Lovely stretch. And you can do that actively. Like I said, it's carrying things is if you can get a little tea tray or something and else have a tea party, get them to carry the tray for you is a nice activity to do, anything that gets those palms up. Also, with the older children, I do lots of card games. So I pass them a card and then they have to turn the card over to look at the card. So matching pairs, you can get that movement for matching pairs with a card is a really nice activity. Also turning pages of a book, you get that supination, which is a nice active stretch to do. Thinking about the shoulder, if you can take arm above head, when usually easier when the child is lying on their back, and get a really nice stretch. Also, if you've got shoulder at 90 degrees, you can rotate elbow, hand to floor and get that lovely rotation going. Or what is a nice active stretch to do is trying to get your child to just get hands behind head if they can. And then the opposite way is just getting hands behind back. So if you can put something behind them, they've got to reach and then pop it behind their head. So just getting behind back, behind head. It's lovely rotational active movement and a good old stretch. What I often use when I'm doing active stretching is to get the other arm involved as well. So I might use some props. So if you've got a football, you've got two hands on the ball, which can be quite tricky with a heavy hand to keep it on the ball. So if you can get a squidgy ball rather than a hard round one, which is hard to get your hands around. So you can just practice lifting it above your head and down again. Things like you can use a pole, just lifting up and down. You can have those pretty batons with the glitter in and the tinsel bits on the end can be really useful. So getting the pole up in the air behind your head and then getting them to reach behind them. Feather boas are lovely. they're a bit more flexible, but if you've got hold of one end and you can sort of wave feather boas from side to side, they're always good fun to get that bimanual activity going. But if you're using the non-affected side, then it really encourages the affected side to get those really good ranges of movement. Also, the cheerleading pom-poms, you can get them for £5 off Amazon, sparkly sort of silver and gold streamers. I'm shaking those up in the air and writing in the air with them is quite motivating, and that's been quite useful. So yeah, that's upper limbs, that's covered. Thumb, fingers, wrist, elbow, supination, and then shoulders. Okay, so just taking that shoulder through all its ranges of movement regularly is really, really valuable. So moving on to lower limb, the cycling legs I talked about before, the younger child is really useful. But what you need to do, let's get the baby back, is when you're bringing one leg up to the chest, what you're trying to do is keeping that leg down flat. So you are, in essence, stretching out the hip flexor. So it's not this leg I'm stretching, pushing up, it's actually the hip flexor. It's a really nice one to do. Stretching out those hip flexors. Really, really useful. And also I talked about abduction, so bringing hips out to the side. That's with long legs. You can do it with bent knees. So cross-leg sitting. Cross-leg sitting is a really valuable position because, as I said before, the affected limb will want to turn in. You'll see a lot of internal rotation, and what we want is external rotation of the hip, much more stable position. So cross-leg sitting externally rotates the hip. So that's a really nice way to sit. You often find children with hemiplegias W sit, or they might side sit. So if this was the affected side, they tend to side sit this way because that hip is still internally rotated. So side sitting in the opposite direction is fine because you can see we're externally rotating that hip, and that's okay, but cross-leg sitting will probably be tolerated better. So that's a lovely position to be in. Now those hamstrings get very, very tight. The hamstring muscle at the back of the leg, it passes over the knee joint and the hip joint. So to get a decent hamstring stretch, you have to have 90 degrees at your hip and you have to have a straight knee. So if the child is lying down, you haven't got a great stretch because you've just taken that tension off the hip. Sitting up, when they bend their knees, then again, you've lost the stretch. So it's that long leg sitting, back against the sofa, just watching television in that position. You'll find that they will slump down a bit and then their knees will bend a bit, but just a little reminder to sit up straight, that lovely hamstring stretch. I don't know many children with a hemiplegia who haven't got tight hamstrings. So this is a really useful position. So for little ones, you can sit in front of them and sort of do row the boat. So you fix your legs over their legs, doing row the boat, and you're doing a little hamstring stretch there, which can be quite useful and fun. Sometimes use gaiters. I don't know whether people use gaiters. So it's like a big piece of material with metal struts down that you wrap around the leg, basically to keep a limb straight, a joint straight. So you might use it on the leg to keep the knee straight, then you don't have to worry about bending and straightening, and you can hold in that position. Also for arms, you can put them on arms. So if you're doing weight bearing activities, you've got a straight elbow, so you don't have to worry about holding the elbow. You know that's going to stay there, and you can be busy entertaining the children. And another really valuable, and the last one I'll go through for stretches, is the calf muscle. So for a calf stretch, I won't show you the passive one, an active one for an older child. So you need foot flat on the floor, pointing forwards. This front leg can bend a little bit, but you're stretching all the way down the back of the leg. Again, this muscle passes over the knee and the ankle. So you have to have a straight knee. If you bend that knee, then you've taken the tension off that stretch. So you need a straight knee and you need that foot flat on the floor. So you're getting that lovely stretch down the back of the calf into the heel. which is good. But the passive stretch, you've probably all been taught if you need to do it, is bringing the foot up into 90 degrees, which I won't go to any detail now. I'm sure you're all aware of that. I can do later if people want a reminder of the passive gastroc stretch. I can certainly do that. Moving on, one of the key focuses of treatment in hemiplegia is weight bearing. Pretty standard, you have reduced weight bearing in your affected side, and it's really important that you get aligned weight bearing through both the arm and the leg. So reduced proprioception and that sensory neglect can really reduce the ability to weight bear. So it happens in arms and legs, and it's really key that you work on aligned weight bearing. You can do it through positioning, functional activities, and play. And I'm going to run through a few ideas on weight bearing. So upper limb weight bearing, the 4-point kneel position. So I use that all the time. So with younger children, we do animal games. So we do the elephant song, which I love. So the child is in 4-point kneeling, weight bearing through arms and legs, and you can do stamping, singing, stamping, bear walking, any games and singing like that, but you're getting weight bearing in a 4-point kneel position. It's not rocket science, but it's so hugely valuable. Like we said before, you're getting that lovely stretch, you're getting proprioceptive feedback, you're developing stability around the shoulder, core stability, loads of really useful therapy in that 4-point kneel position. Now, if your child can 4-point kneel quite comfortably and you want to challenge them, then what you need to do is get them to reach forward with one arm. So they're still in the 4-point kneel position, but one arm is coming forwards. So if you can have the affected side weight bearing, the non-affected side is lifting up. So either reaching for jigsaw puzzle pieces, reaching for anything. I often do hoop games. So I get the child to hold their arm out and put hoops, quoits along their arm and see how many I can get on the arm before the other side collapses is lovely. So doing that alternate arm raise is really valuable, but the weight bearing side is going to be on the affected side. And when I'm talking about aligned, it's really important to make sure that the elbow is directly above the wrist and the shoulder is directly above the elbow. So you've got that alignment. You don't want it out here or in weird and wonderful positions. You want that alignment so that the force is going directly through the shoulder into the hand. So that's what we talk about, alignment. If it doesn't look right, then it's probably not right. So just straighten it up and make sure you've got the alignment. Exactly the same with the lower limb. Make sure that the hip is directly over the knee, is directly over the foot. So you've got that lovely aligned weight bearing, which is really going to help that hip development. So back to the upper limb weight bearing. Again, if you've got a child that tolerates 4-point kneeling, you can work a little bit on strengthening. In that when they're in the 4-point kneel position, you could try some little baby press-ups. So they're still in 4-point kneeling, they're not in the full press-up position, but they're getting their nose down to the floor and coming back up. So you're really looking at that lovely elbow extension, pushing up to the shoulder girdle, lovely flat hands. So it's that box press up. If the 4-point kneel box press up is too difficult, you can do it in standing against a wall. So a few steps away from the wall, and you're going to be leaning forwards and pushing back to extend elbows. So that's the easier option against the wall. If that's not too challenging, then maybe try a chair. So you've got a little bit more gravity behind you now. So nose is down to the chair, and then following it down. So coffee table, nose down to coffee table, and eventually into the 4-point kneel position. But those sort of mini box press ups are really useful because you've got that flat hand, weight bearing through the arm. Lots of lovely information. High kneel propping is really useful. So with a child can achieve a high kneel position, that position, and then having a surface in front of them that they can just put their hands on. So again, you're getting that lovely weight bearing, but it's not too strenuous. There's not too much gravity acting down. So they should be able to keep a nice flat hand on the bench and just a little bit of propping and weight bearing. And you can move the bench little bit further away so you get more and more weight bearing. But high kneel propping is another lovely upper limb weight bearing activity. Gains over a therapy ball, or I've got a peanut here, peanut ball. I think this is a really useful piece of equipment. This is the 30 centimetre one, so it's for smaller children, but it does go to sort of ages, probably about 7 would be fine. So gains over the ball. So reaching forward, so hands going onto the floor. Obviously, the older child should have longer arms. This baby's a little bit small for this. But hands coming down, and you can do some wheelbarrow walking over the peanut ball. But they often enjoy that. It's good fun. So tummy lying, going forwards, wheelbarrow walking over a therapy ball or a peanut ball, which is a little bit more comfortable, is a nice upper limb weight bearing game. Side sitting, beautiful. So again, make sure that the affected side is the side that is doing the weight bearing. And just getting your child into that side sitting position, and you need the toy or the book or whatever you're playing with diagonally opposite. So this arm is reaching over to turn the pages of the book, or just observe the book and have a book read to them in side sitting position. So you've got lovely weight bearing going through that hand. Okay, so that's still aligned, although it's not directly underneath, it's still aligned because you've got shoulder, elbow and wrist all in a straight line. So that's that lovely side sit position, which is really helpful. Again, you can use a gaiter just to keep the arms straight if you need to. But side sitting is fantastic. And then that facilitated movement sequencing I've talked about before. So if you've got a child who's not able to sit up by themselves yet, and you're encouraging them to do it themselves, this facilitation, taking them up into sitting and just waiting, give them time to wait, put the hand down and pushing up into sitting, it's fantastic. If a child is more advanced, you can ask them to move from side sitting into 4-point kneeling, back into side sitting again, keeping this affected arm flat on the ground. So you're getting lots of mobile weight bearing over that arm, which is a really lovely activity. Also, you can play reaching games, so get them to reach something that's dangling up here. They're actually pushing up to reach and come back down, pushing up, coming back down. So lots of weight bearing through that arm. So very quickly, I know I'm running out of time here, lower limb weight bearing activities. Just standing and transferring weight from one leg to the other, rocking from side to side, really lovely. So just try, I can't do it with this baby, but feet flat and literally just transferring your weight from one side to the other through an aligned lower limb is lovely, just stimulating weight bearing through that affected side. Step stand play, a little bit more advanced. So your affected side is on the floor, and if you've got a little step in front of you, the opposite leg can be on the step. So basically you're taking all the weight through that affected side, so you can play at a table without them really realising, have this foot on a step. So they're really having to work hard here, stimulating all the muscles around the pelvis and around the knee to keep that leg aligned. And so step standing, really useful. If they're even more advanced, don't use a step. You could use a ball or another slightly unstable object to stand on. Clock stepping, I like. So you can use a little hoop. So stand in the middle of the hoop and imagine it's a clock face. So you've got 12, 1, 2, 3, etc. And then ask your child to step on number 1, number 2, number 3. So this affected limb is staying still, not moving, but the other one is moving directions. That's a nice dynamic activity. You can just have coloured dots on the floor. So step on the blue spot, step on the green spot, step on the red spot, but just keeping that affected limb weight bearing the whole time and moving the other one around. Also side stepping, getting your child to side step, leading with the affected limb, lovely weight bearing through that side, and step ups. So if you're working on step ups, you want the affected limb to be doing the stepping. So they've got to push up and down. So the affected limb goes up first and they push up. The step ups are lovely, just on a little step. You can use books. It doesn't have to be a big stair, obviously, depending on how big your child is. So strengthening exercises, there are 1,001 different strengthening exercises for multiple muscle groups. And obviously they have to be very bespoke to your child's area of need. So I won't run through those now, but if anybody has any specific problems, let me know, and I can try and suggest some strengthening exercises. Also, be very mindful of positioning, where your child spends a lot of time. So if your child spends a lot of time on the floor in W sitting, try and discourage this, because that's the internal rotation of the hip the whole time, and you don't want that. You want alignment, you want symmetry, and you want to avoid encouraging abnormal movement patterns. So just think about positions they're in. So when they're sitting at a table, make sure feet are flat on the floor, elbows are resting, so you've got that nice stable position in which you can work on, rather than an asymmetrical position like this. You're working for symmetry and support, so be very mindful. And also about the way you approach the child. With the younger ones, if you approach them from their affected side, get them to turn in that direction, being more aware of what's happening on that side of the body, rather than always approaching them on their non-affected side. So I'm aware that it's nearly 9 o'clock. I haven't talked about the adjuncts to physio, or the toy suggestions and things. I can run through them really quickly, or maybe do another session about those, but I think I've covered the physio side of things, and hopefully given you a bit of an idea about stretches and activities. They are quite generic, but with a hemiplegia, it is all about alignment, weight bearing, and preventing contracture, working on symmetry in most cases. So hopefully that has given people an idea of things that they can use and to be mindful of and aware of, and know where to direct the therapy. So Jenny, do you want me to whiz through, or shall we do another session?
I am entirely happy either way, so whatever you would rather do. If you have time to do it now, I think you've got your captive audience.
Yeah, I'll go through the adjuncts to physiotherapy now. That would be great if we could quickly run through those.
Okay, perfect.
So like I said, these aren't the hands-on physio skills, but they're things that physio use to help children with hemiplegia. So splints. A lot of children with hemiplegia use splints and orthoses. So starting off with the very little ones, we often suggest using supportive footwear, so little boots that just stabilise the foot. A lot of children are given NHS-wise little Piedro boots. They're quite heavy, Piedro boots, but they're nice, stable shoes that give you a real grounding to develop other skills. But basically just supportive ankle boots that keep the foot flat on the floor is what you're looking for. So we often start with little boots. Then we might work on to other orthoses, so we can have insoles. So if you've got a foot that's rolling over, just having a little insole in your shoe just to correct that foot alignment. So if your foot's in the right place, you're more likely to have your knee in the right place and your hip in the right place. So it works top down and bottom up. But if you've got an unstable foot, just having a little insole to correct that foot position can be really beneficial. If an insole isn't enough, then we can have stronger splints. I often use DAFOs, which are dynamic ankle foot orthoses for children with hemiplegias. So hemiplegic, they just come up to the ankle. They still allow movement around the ankle, but they control that foot position. And they also have little lumps and bumps in them that help to reduce the tone in the foot and stop the tiptoeing. So a DAFO can be really useful. You've still got that freedom of ankle movement, but it's a nice splint that helps stabilise and reduce tone in the foot. If a child isn't getting heel strike when they're walking, then we often use an AFO, which is an ankle foot orthosis, which you've probably heard of, which are, they go down the back of the leg and under the foot, and they lock the ankle at 90 degrees. So basically, when you're walking, what we want to achieve is a nice heel strike it's a bit of complex physics, because if you don't get your heels straight, you get your toes down first, then the ground reaction forces from the ground shoot up in the wrong direction and cause you to lock your knee. And if the ground reaction force goes behind, then you get a flexed knee. So basically what we're trying to do is improve the alignment of the foot. We might use AFOs also to control a really mobile foot. So if the DAFO doesn't work, then an AFO has 3 points of control and it's much stronger. So children who are very unstable might require AFOs to stabilise their foot. So those are sort of the main splints that you see used in the hemiplegia. We sometimes use shoe raisers. So if a child has got a real leg length discrepancy, then you can have a little raise, because if you're getting symmetry when you're walking, then obviously it's going to prevent any deviation of the spine and the pelvis. So we often use shoe raisers if they're required. It's usually, we say, I think it's about 2 centimetres. If there's a 2 centimetre or greater difference, we would use a shoe raise. We also use lycra. You may have heard of lycra splints. So they're dynamic splints. So it's like wearing a sort of little wetsuit. You can have whole body suits. You can just have shorts. You can just have gloves. We call them gauntlets. And basically, it's like a neoprene material, which has various stitches in it, which try to facilitate movement. So if you've got a pronated forearm, you can wear a gauntlet with stitching that just gently supinates the forearm. And the same with the wrist. You can have one that just encourages that extension of the wrist. So lycra is lovely. It's not rigid. It's usually well tolerated. They can be quite tricky to get on sometimes because they are quite tight. So it's like in a wetsuit on sometimes. Obviously with little ones that can be quite difficult. But lycra suits can be really, lycra garments can be really useful in hemiplegia as well. They can be used around the ankle and the foot as well as the upper limb. Wrist splint. So if you've got a child who holds their wrist in flexion, which like I said is not a functional position, just having a little wrist splint that just holds the wrist in that position can be really helpful. It's a much more functional position and it prevents that contracture from occurring. So often children can have a little wrist splint just to hold that wrist up in extension and make it easier to have a functional hand. The thumb I've talked about, children often have thumb splints, little abduction splints, just to keep that thumb out. Like I said before, if the thumb's out, it does have an impact on the whole hand. So if you can have a little thumb splint, OTs are good at giving out little thumb splints just to keep that thumb out, but that's something you might see or find really useful. I've mentioned gaiters, that you wrap around a limb to keep either an elbow or a knee generally straight. It can be just like another pair of hands, which can be really useful when you're trying to do weight-bearing activities on arm and leg. Just means you know that that knee or that elbow is being held straight, and then you can work on weight bearing. So gaiters are very regularly used. So you may also have heard of Botox. So Botox is injectable into a muscle and it temporarily paralyzes the muscle. It can be really useful in hemiplegia. Can be used in the arm and in the leg. So basically, if you've got an overactive, very spastic muscle that's getting quite tight and leading to contractures, if you can knock that muscle off for a while, it is important when you have Botox that you don't just have Botox and that's it. You actually need to really work when that Botox is working. So if you imagine you've got, you're having Botox in your bicep to stop this. So if you knock the bicep off and allow more elbow extension, what you need to be doing at that time is working on that extension. So strengthening up while you've got the opportunity, strengthening up that opposing muscle so that as this comes back into life, as the Botox wears off, you've got a much more functional and strong muscle in the opposite muscle group. So you really need to work with physio when you have Botox and maximising the effect of the Botox. It's all about rehabilitation afterwards, not just having the Botox, but it can be really beneficial. Then there's things like electronic stimulation, which is becoming more and more mainstream. There's FES, you may have heard of, functional electronic stimulation. So you see children with little packs on their legs and little leads coming out. So they're just stimulating active muscles. So it's for cases of weakness. So maybe for toe lift when walking, it just triggers a contraction so that the foot lifts up. And sometimes you can have a pressure pad in your shoe. So when the foot comes up, it knows to stimulate the dorsiflexion. So you get a nice clearance and the foot goes down and you get that nice walking pattern. So it's an electronic stimulation, and that's becoming more and more mainstream. I'm seeing more children using FES, which I think can be really, really valuable in hemiplegia. Then moving on to more complex biofeedback technology, which is really out there at the moment. I work for a company, I do a bit of consulting for a company called Hobbs Rehabilitation, who are one of the UK's leading physio services that are using this technology, and it's quite phenomenal. One that I have used is called the Grippable. So it's basically just a little handheld device which can link up to a tablet or a television, and you can do gaming with it, and it just gives you that biofeedback, which is brilliant for children. They love it, and it develops appropriate movement patterns and gives some real positive reinforcement, and that is quite exciting. So it's all through virtual reality and neurotechnology. So that is coming. At the moment it's crazy expensive, but it is out there, and it's something that just to be mindful that it's out there. And one last thing is constraint-induced movement therapy. You may have heard of, I don't know. Possibly controversial, but it has its place. So basically that means inhibiting use of the non-affected hand so that the child has to use their affected hand. And practice makes perfect. And it's obviously done through a very controlled rehabilitation program. But basically you're laying down pathways and learnt movement and getting the child to use their affected limb more. So yeah, that is out there, and there are places that are doing that therapy. So that's something else just to think about. So I think I am going to stop there because I have bombarded you with so much information. But hopefully, because this is being recorded, you can dip in and out and use the useful bits. Yeah, and I can pass on any other information to Jenny and maybe take any questions if we want to have questions on a separate occasion, if people need to rush off. I don't know.